Welcome to this educational program, and congratulations on taking an active role in your healthcare. It is our sincere hope that this program will enhance the discussions between you and your physician regarding your surgery. This module provides a brief overview of stress incontinence, followed by a detailed review of the mid-urethral sling procedures, including how they work, expected outcomes, and potential surgical risks. This information is taken from a recent review of the medical literature and attempts to be as transparent and comprehensive as possible. However, the figures quoted may not necessarily reflect the experience of your surgeon. A more detailed background discussion of stress incontinence can be found in a separate module. This program is divided into two parts. Should you choose, you may use the buttons on the left of your screen to navigate back and forth through any of the slides, or to pause and take more time to review a slide. The first part of this program briefly explains your condition and gives some insight into factors involved in your surgeon's choice of this procedure. Part 2 discusses the procedure in detail and reviews the current literature with respect to outcomes and potential risks. This section aims to be as all-inclusive as possible, listing all important potential complications quoted in the literature. Single case reports are not necessarily listed. However, when 2 or more case reports are published, the complication is listed as rare. Introduction. Urinary incontinence simply refers to any involuntary loss of urine. It does not, by itself, say anything about the cause of the problem. Normal urinary continence, or control, requires a normal and relaxed bladder, an intact, properly functioning pelvic floor, or supporting structures below the bladder and urethra, and a normal urethra, or urinary passage. Any abnormality of any of these components may lead to incontinence or loss of urine. Stress incontinence is the loss of urine associated with increased pressure within the abdomen. This may occur with coughing, laughing, bending, lifting, sitting up from a chair, physical exercise, sexual activity, or any other form of straining. In very severe cases, it may occur just with walking or being upright. It should be pointed out that approximately 30% of patients with stress incontinence may also have a problem with an overactive or spastic bladder and incontinence related to the inability to suppress bladder urges. This is important to understand in terms of your expectations, because treatments for stress incontinence will not necessarily improve all of this so-called urge incontinence. Prior to surgery, you will likely have tried conservative measures, such as Kegel exercises, to treat your stress incontinence. You will also likely have undergone some testing, including a detailed pelvic exam and possibly also a cystoscopy, which is an internal bladder examination, and urodynamic studies, which are bladder function tests. If other problems, such as an overactive bladder, exist, these may have been already treated with medications. Like many procedures for stress incontinence, the retropubic mesh slings provide excellent cure rates in the treatment of stress incontinence. As mentioned earlier, however, if you have other associated bladder problems, such as urge incontinence, these will not necessarily be cured by surgery. The aim of surgery is simply to improve the structural problem leading to stress incontinence. It is important to understand that your doctor has chosen this operation for you from a list of more than 100 described surgical procedures for stress incontinence. While there is no single best procedure, there has been an evolution in surgery towards less invasive procedures which still provide excellent cure rates. Mid-urethral mesh slings have proven to be the first such minimally invasive procedure to provide durable cure rates in large numbers of patients. Numerous other factors have also gone into your physician's choice of surgery, including your age and general health, the severity and bother of your incontinence, prior surgeries you may have had, coexisting conditions, as well as his or her own training and experience, availability of product, hospital resources, and others. Before entering into the details of surgery, we would like to close this section with the following reminders regarding treatment for stress incontinence. Firstly, while much of the data we will present focuses on outcome statistics, at the end of the day, our most important goal is to improve your quality of life. Having said that, however, we must understand that there is no perfect operation for stress incontinence, and we can never guarantee that any particular result will last forever. Any individual patient may respond differently to any individual procedure. By its nature, any operation for stress incontinence may alter the dynamics of bladder storage and bladder emptying following surgery. Finally, surgery does not eliminate the need for ongoing lifestyle modifications and exercise, which you may have been counseled about previously. These measures are still necessary to maintain lifelong pelvic health, prevent future problems with prolapse, and enhance the durability of your surgery. Now we will go into the specific details of the mid-urethral sling operation. The sling, also called a tape, is made of various materials and is placed loosely under the middle part of the urethra or urine tube. Usually, the tape does not require fixation with stitches or other anchoring devices. These slings work by reinforcing the normal supporting structures on each side of the urethra, and by providing a backboard of support underneath the urethra to allow it to compress and prevent leakage when downward force from the abdomen is applied, such as coughing or laughing. The tape is placed rather loosely, so that during urination there is no obstruction of the urine flow. This is an example of a typical piece of mesh used for these slings. These procedures are usually performed as an outpatient procedure, meaning that the patient goes home on the day of surgery, and they are usually done with local anesthetic or freezing combined with some sedation. Slings, or tapes, differ in many ways. They can differ by the material used to make the sling, the location of sling placement along the urethra, and where the sling is positioned in the pelvis. Today, most slings are made of a synthetic mesh material, and almost all slings are placed under the middle part of the urethra. Therefore, sling position in the pelvis is the main differentiating feature amongst these procedures. There are two main types of mid-urethral slings, as determined by their position in the pelvis: the retropubic slings and the transobturator slings. This is an illustration of a retropubic tape or sling. Retropubic means behind the pubic bone. As you can see in this drawing, the blue tape sits loosely under the middle part of the urethra, with the ends of it passed up behind the pubic bone. This is an illustration of a transobturator sling. Transobturator means across the obturator space. As you can see in this drawing, the blue tape sits loosely under the middle part of the urethra, with the ends of it passed across the pelvis through the obturator space. Mid-urethral slings have been performed since 1994 in Europe and since 1997 in North America. With far more than 250 papers published on the operation since 1996. By 2005, more than 700,000 of these operations are estimated to have been performed. And 7-year follow-up data is available on a small number of patients. The concept of placing the sling across the pelvis rather than behind the pubic bone came about in 1998. This concept began being put to clinical use in Europe about a year or two later. And 2-year follow-up is now available in small numbers of patients. Studies on small numbers of patients with short follow-up time have been done to compare the two approaches. While there may be theoretical advantages of each type of sling, to date there is no strong evidence to support one over the other. For each type of sling, there are many products on the market, made by many different companies. And again, there is no strong evidence to support the use of one product over another. Slings may differ by the material used for the mesh, the weave of the mesh, the device used to pass the mesh into the body, and the direction that the mesh is passed into the body, among other things. At present, the decision as to which product is chosen is largely subjective, depending on the surgeon's preference and availability of product. The following information is meant to be generalizable for most slings on the market. However, details may not necessarily reflect the experience of your surgeon. Regardless of the sling chosen, there are several advantages of these products in the field of stress incontinence. First of all, relative to other operations, these slings provide excellent short and medium-term results. The procedures are relatively safe, with the most common risks being minor, and the more significant ones being rare. These procedures can also be done on an outpatient basis and under local anesthesia, making them more tolerable for patients and limiting the use of healthcare resources. The procedures also limit downtime for patients, allowing them to return to their normal activities faster than more invasive procedures. Furthermore, unlike some other procedures, mid-urethral slings remain highly effective in traditionally more difficult clinical situations, such as when previous surgery has been performed, when other procedures such as a hysterectomy or prolapse repair need to be undertaken at the same time, or in obese patients. Finally, these slings have been shown to have no major negative impact on sexual activity. Now we will review what to expect on the day of surgery. This discussion assumes that no other repairs are being done at the same time. On arrival into the operating room, you will be given an anesthetic or some sedation through your IV, and your legs will be placed in stirrups. The skin of the lower abdomen and thighs, as well as the vaginal area, will then be cleansed. Surgery is then performed through 2 small incisions just above the pubic bone, for retropubic slings, or on the inside of the thighs, for transobturator slings, plus 1 small incision in the upper vagina. Absorbable stitches are used, which will dissolve in a few days to a couple of weeks after surgery. After the procedure, you will be taken to the recovery area. Once your bladder is full, you will be asked to urinate, and your bladder emptying will be assessed by a nurse. If you are unable to empty your bladder well, then you may be sent home with a catheter, or taught to self-catheterize, or in some cases, kept in hospital longer. In some centers, you will be followed up by a home care nurse to be sure that you are recovering well and emptying your bladder satisfactorily. It is not uncommon following these procedures to note an increase in urinary urgency and frequency of urination, and if bothersome enough, this may even require medication to relax the bladder. Mild discomfort of the lower abdomen, thighs, or vaginal area is also not uncommon. However, significant pain is unusual. Many surgeons will prescribe an oral antibiotic to take for a few days following surgery to prevent infection. As noted, the stitches used in this procedure will dissolve on their own in a matter of days to a couple of weeks. It is important to note that rarely patients find that they cannot empty their bladder at all after surgery. In the rare event that this situation arises, you should notify your surgeon immediately, as the sling may simply need to be loosened. You should try to rest for a few days after surgery, but most women should be back to normal activities very quickly. The exact amount of time off from work you may need will be left up to your doctor. Heavy exertion, along with sexual intercourse, should ideally be avoided for 4 weeks, until the area is well healed. We will now review some of the results reported from surgery, from the large numbers of papers published. As mentioned at the beginning of this program, some of these slings have been around at most for about 10 years in Europe and 7 years in North America. Unfortunately, most of the studies available for review have published only short-term follow-up. It is important to recognize, therefore, that while we can confidently speak of this procedure's excellent short-term success, the honest truth is that we cannot guarantee these results for a lifetime, because we simply do not have long enough experience yet. In the short term, the mid-urethral slings appear to be effective in 85 to 90% of patients based on patient reports of success. When very tough criteria are applied to evaluate incontinence, the cure rate may appear lower. However, patient satisfaction remains very high. It has been shown also that this operation can dramatically improve patients' quality of life. Medium-term follow-up data is only available on a small number of patients, but does show that the excellent early results appear to stand the test of time. The risk of any surgery may be divided into those that occur in the operating room, or intraoperative, and those that occur following surgery, or postoperative. The most common event that may occur in the operating room is a minor injury to the bladder. This is almost always recognized and dealt with at the time of surgery by looking into the bladder with a small telescope called a cystoscope. And generally, the only effect it may have on a patient is that they may require catheter drainage for a short period. This is a more common occurrence with retropubic slings compared to transobturator slings. Other risks, such as injury to other structures and bleeding, are rare. Following surgery, the common important complication to be aware of is the possibility of temporary problems emptying your bladder. This has been reviewed earlier, and as noted, temporary catheter drainage or self-catheterization may be required in up to 27% of patients, with an average of about 10%. Complete inability to empty the bladder is uncommon, occurring in about 1% of cases. Also, as mentioned earlier, an overactive or spastic bladder may develop after surgery, which may occur in up to 10% of patients. This may require medications to relax the bladder muscle. Bladder infections may occur in 4% of patients, and these are usually minor. More serious infections, such as an abscess or collection of pus, are rare. A pelvic hematoma is a collection of blood in the pelvis, like a large bruise. This is also unusual. Finally, given that the sling is a foreign synthetic material, it may erode through the wall of the vagina, or through the bladder or urethra. This complication is also relatively uncommon, with an overall erosion rate of 1% or so. Overall, and compared to previous methods of dealing with this challenging problem, the mid-urethral mesh sling appears to be a safe and very effective operation. Patient satisfaction rates are very high, and most potential complications are minor, common to all such operations, and can be successfully treated. This concludes this presentation on mid-urethral slings for urinary stress incontinence. This sample of modern references is available for review from your local medical library. We hope that through this presentation you have gained a greater understanding of urinary stress incontinence and the mid-urethral sling procedures. We wish you the best for the future and thank you once again for viewing this educational program.